Welcome to the Radically Genuine Podcast. I'm Dr. Roger McFillin. It's about 100 degrees today in Bethlehem, Pennsylvania. So in our new studio, the air conditioning isn't exactly working as we would hope. So it's a little bit warm in here, but I'm so grateful for my guest today, Dr. Ragy Girgis. Welcome to the Radically Genuine Podcast.
Thanks for having me, Roger, and thanks for the directions, the hospitality, and also thanks to your team.
Yeah, I mean, I'm really fascinated by your work. It's very difficult for a psychiatrist to come here and have a long-form conversation with me. I've been asking for it for years, so I'm so incredibly grateful. Can we just start with a little bit about who you are personally and professionally in your journey into psychiatry?
Sure, thank you. I went to medical school at the University of Pittsburgh. I really went into medical school not knowing anything about psychiatry. I had a great experience with research during the summer after my first year of medical school, and then I had a great time on my psychiatry clerkship in the third year of medical school. After that, it was very clear to me that I needed to go into psychiatry. I matriculated at the adult residency program at Columbia. I completed the 4-year residency there, then a 3-year clinical fellowship, and I've been there ever since.
So when you first entered into medical school, did you have any intention at that time to maybe entering into another specialty area prior to psychiatry really grasping your attention?
Right. Well, that's a good question. I think I probably told people at the time that I was thinking of orthopedic surgery just because that's what I was kind of supposed to tell people. I worked out at the gym. I was kind of a bro to some degree, even though that might not seem that way. So I kind of told people I was probably interested in orthopedics, but I really wasn't.
So in addition to your academic work at Columbia, do you actively see patients at all?
I used to. So what happens with, and also because I do clinical research, so my research involved patients, but in terms of having a pure kind of clinical component of my career, what happens and what I was told when I began my research career is that after residency, if you do end up doing research, I would have a private practice, which is typical for people at Columbia who do research for about 10 years. And at that point, it would become too difficult for me to balance clinical and research duties. And that's exactly what happened. After exactly 10 years of having my clinical practice, like a private practice on the Upper West Side of Manhattan, I had to shut it down to focus completely on research.
Okay, let's dive into that research. From what I understand, you've built something truly unique, the Columbia Mass Murder Database with, I think there's over 2,200 cases spanning more than a century. Is that accurate?
That's right.
Okay. Let's start there. Your interest in this area and how you've built this.
Sure. I am a clinical schizophrenia researcher. I primarily conduct clinical trials, brain imaging studies that try to understand schizophrenia, ultimately with the goal of developing new medications to treat and potentially cure, but ultimately treat schizophrenia. Now, we're all exposed to mass shootings and what the media says about mass shootings and potential relationship between mental illness and primarily psychotic disorders and mass shootings. Around 2019, a colleague of mine, Dr. Gary Bricado, came to me and said, Ragy, we need to put together a database that will allow us to, as definitively as possible, answer the question of whether and how mental illness, and again, primarily psychotic disorders, are related to mass shootings. And so that's what we did.
Okay, well, tell me about your findings.
Sure. So we put together this database with, like you said, 2,200 cases of mass murder. We initially had 1,600, and it's grown since then. We kind of put it together in 2019, 2020. And I want to even take a step back because the goal was ultimately to examine the relationship between psychotic disorders and mass shootings. But to do that, we understood that we needed to understand more than just mass shootings. So, for example, how research is done, and I imagine a lot of your listeners understand this, but how research is done is that we understand that no research can be perfect. We'll never have all the data that we need. So we understood we needed to control for, these are referred to as biases or confounds. And so what we decided to do, and I think this was the most important decision we made when we decided how to construct the database, is that we decided to include both mass shootings, meaning mass murder involving at least one or more firearms, and other types of mass murder. So we would have at least one other comparison group. That limits bias, limits confounding, and those sorts of things. So we decided to construct a database involving all types of mass murder since 1900. So we could also examine events over time. We also included mass murder all over the world since 1900. So we can examine effects over time. We could examine effects that are different between countries. We can examine differences between when different types of methods are used. So that's how we started. And then we basically just looked online and found as many court records, police documents, and other reliable media sources from which we could obtain data on any type of mass murder. And we should also be clear that we define mass murder as 3 or more victim fatalities, not just injuries, well, certainly not just injuries, and also not including the perpetrator at any one time, at any one place.
So are you just looking at if like a psychotic condition was associated with that murder, or are you expanding? What is your definition of what is mental illness?
Sure. We looked at all different types of every type of mental illness we could find, including substance use conditions. We also looked at neurological conditions, and then beyond that, we looked at to see whether the mental illness, if the perpetrator had a mental illness, was actually motivated by their mental illness. Because, for example, in many cases, you would assume that the mental illness would be incidental. So you probably I imagine a lot of people on this podcast who listen to this podcast know that the prevalence of mental illness in America, the lifetime prevalence at this point, is around 40 to 45% if we include anxiety disorders and other sorts of conditions. So we examine not only the prevalence of mental illness, all sorts of mental illness, including depression, psychotic disorders, et cetera, as well as in how many cases mental illness, again, we're really talking about psychotic disorders, was the motivating factor in the perpetrator's mass murder and killing of 3 or more people. So that's what we looked at. We had about 1,600, 1,700 cases originally. Like that's the number that we published in our original paper. Again, now we have 2,200. What we found was that the percentage of people with a mental illness, or specifically a psychotic disorder, among people who perpetrated a mass shooting was 8%. That number among people who committed mass murder using another method, like any method besides a firearm, for example, knives, hammers, any sort of blunt object, was 18%. That difference was significant. The reason why examining differences between groups is important is, again, because there's a lot of bias and confounding in these numbers. For example, we can't be sure we have all of the information available about these people. We can't be sure that there are other reasons that might lead to an association between psychotic disorders and mass murder, or psychotic disorders and something else, or not lead to this association. So we had to compare groups that limits bias and confounding. Again, the groups need to be as similar as possible. So 18% in the mass murder group when a firearm was not used, 8% when a firearm was used. Those are also called mass shootings. The difference was significant. That speaks to specificity. Specificity is one of the 9 Bradford Hill, or people also know them as the Hill criteria of causation, published, I think, by Bradford Hill in around, I want to say 1968 or something like that. So to understand causation, so to understand whether psychosis or mental illness actually causes mass shootings, or there's any causative link between 2 variables, one needs to know more than just whether there's a correlation. People know this as, or understand this, or have heard this as something along the lines of causation. Correlation does not equal causation. That's true. That comes from the Bradford Hill criteria. Correlation or association is one of the 9 criteria. The other criteria, and I'm not going to remember all of them, are things like specificity, so understanding that the relationship is specific to, for example, psychosis and mass shootings, rather than also psychosis and mass murder with other methods. And again, in this situation, we found that there isn't actually a relationship between psychosis and mass shootings, whereas there is with psychosis and other types of mass murder. Other criteria for causation include the strength of the relationship, whether there's like a dose response, reversibility, experiment, meaning whether you could produce this like in a lab. That's obviously not possible with some sorts of associations. There's coherence, plausible mechanism, all these sorts of criteria. So specificity was the one that we focused on.
Okay. So you mentioned earlier about the large percentage of people that have been diagnosed with quote-unquote mental illness in the United States. I think you just mentioned over 40%. That seems quite high. Those who've been on my podcast before, we've addressed this subject. Isn't that related more to the expanded diagnostic, lowering the threshold and going from what amounts to 106 mental illness diagnosis in a DSM from 1952 to like more than tripling it to today. So is mental illness actually a valid scientific construct that one can measure?
Yeah, definitely. You're right. There is a reason why there's so much more mental illness now than there was, say, 30, 40 years ago. It might be less the number of conditions in the DSM and more things like earlier identification, less stigma, those sorts of things, a somewhat expanded definition.
Well, they've lowered the threshold to obtain a diagnosis. I mean, let's look at major depressive disorder, right? So what's the difference between someone who meets those criteria in, let's say, 3 weeks versus 10 days? I mean, is there anything medically different from the two people?
Well, there are, I guess we'd have to go back to how these diagnoses are kind of understood and how they come to be. So basically, your listeners probably already know this, but the DSM was developed based on, or has been developed based on, a lot of people getting together, reading the studies.
Consensus over, clear objectable measures and assessments, right?
And yes, and then the criteria that they develop are then subject to field trials. So they test the validity, reliability, and other statistical parameters of these sorts of conditions, and that then leads to kind of diagnoses that people feel comfortable with, and then make sense. So it's not necessarily that they examine.
Can I argue against that for a second?
Please.
The fact that they're valid constructs has never been proven. In fact, there's diagnostic overlap in all of the conditions, like so many of them. So when you look at the DSM, it's very clear that it's more of a categorical representation for communication purposes. I think it's expanded way beyond there, trying to identify it as discrete, identifiable medical conditions, but it doesn't have the science to necessarily support that. That's why you see so many people being provided so many diagnoses. Someone comes into my center, for example. It's very rare for me to see somebody who hasn't been in the medical system that doesn't have some label, because that's required for insurance reimbursement, right? So there's a system here that works together. So someone comes in and they're just complaining about general symptoms. Maybe it's like inattention, difficulty focusing, lower mood, low motivation. Boom. All of a sudden, they've got a mood disorder and ADHD, right? Right on there, just a categorization of symptoms. That's different than saying we have this very clear, identifiable, discrete medical illness that certainly can be reproduced over time. So that's like the challenges of, I think, saying that mental illness in itself doesn't lead to this or does lead to this, because it's up in the air about what mental illness actually is.
I hear what you're saying. There are 2 points we need to bring up. First, I'll address the second point first. The question of whether we can even say anything about a relationship or no relationship between mental illness and mass shootings in this case first. We can, because if that were the case, if the criteria for mental illness were very weak, or if mental illness is really not a reliable construct, using a comparison group would account for that bias. That's the point of using a comparison group, because that limitation, or that's referred to as, that's one type of bias.
All right. So what's the difference? So if you're going to label one of the groups as having mental illness, what criteria are they meeting, and how are you gathering that information?
Right. We gather it from police records, court records, media reports, those sorts of things.
Is that valid? Is that reliable?
So you're right. That might definitely, and that is one of the limitations of disorders. That is not complete. Of course, that's going to be less than 100% valid and reliable. However, again, that is then the point of using the comparison group, because that same bias, like the same problems with validity, the same problems with reliability, apply to the comparison group. So that's why we use groups, because then that bias cancels out. Not perfectly, not completely. There's always bias, and this sort of bias and confounding in all the work that we do. But having the comparison group limits that. So for example,
I would argue that's not necessarily bias. There's not enough evidence to support a designation. So if you don't have clear, discrete evidence, it's very hard to provide that person with a diagnosis. So for example, let's say the media reports that Dr. Roger McFillin has, let's say, a potential neurological condition, okay? But there's no scientific investigation into that. There's no hard objective data. Then how can you assume that is a valid representation of that diagnosis?
Sure. Well, that is a limitation of that sort of method of determining someone's diagnosis. But again, that limitation, or the technical term is bias, also applies to the comparison group. So
But I don't think it's bias. Bias would be having a preconceived notion about something, right?
That might be a personal bias, but there are other types.
But this is about data gathering. So does it meet the scientific method? Can you scientifically scrutinize it when you don't have the objective data?
Well, this might be a semantic issue. Bias, there's personal bias. I understand when most people hear the word bias, they think that this is my opinion or my kind of impression of things or my ideology, something like that. That is one type of bias. That's like an investigator type of bias. But any sort of noise that enters into a system can be considered bias or confounding. Confounding if it is fundamentally related to the variables of interest and is not introduced by the investigator or by the investigation, and then bias if it's introduced by the investigator, so like my own personal bias, I don't think anyone has psychosis, or I think everyone has psychosis, or a product of the investigation, such as limited means of collecting data and not collecting a full sample, et cetera, because we can't. So all research has bias. That's why we use comparison groups.
But it's why we try to use like randomized controlled clinical trials, comparison to placebos, and
Exactly.
That's a way to limit those variables and try to make it, as hard science as possible when we're trying to observe something. But if we're
that's the best way, exactly. That's the highest level.
If we're starting from the beginning, we have no way to confirm if somebody's mentally ill or not. How would you come to a conclusion that, say, mental illness doesn't influence violence, for example?
Right. Well, these are two separate points. I'll get to the validity of psychiatric conditions. That's separate. But say psychiatric conditions have 10% validity. That's equivalent between the groups. So we identified, for example, again, so if the lifetime prevalence of psychiatric conditions is 40%, regardless of the validity of the psychiatric conditions or the ability to diagnose the psychiatric conditions, and we identify 45 using the same criteria, there's a difference of 5%. And so we can say, which is exactly what we found, that about 5% of mass shootings is related to mental illness, and in particular psychosis. And that's exactly what we found. Now, that doesn't speak directly to the validity of the psychiatric conditions. So then if we speak to the validity of the psychiatric conditions themselves, there are a number of ways to confirm the validity. One, they use the gold standard, and the gold standard was expert, basically, not just opinion, but expert diagnoses, essentially. Now we're going back to the DSM. So they compared their criteria with expert diagnoses. And at some point, every gold standard is not going to be perfect, but that's what they used.
Is that like you're going back in time and you're trying to like determine a diagnosis by reading what, like other people's accounts of it?
No, with regards to the DSM field trials, they did this in a very rigorous way. Like they had their criteria, they had the mental health practitioners, psychiatrists, psychologists, and other people who had a lot of experience with certain people, and they would have people administer the DSM criteria or ask about or obtain the DSM criteria, and then compare that to the conditions or the diagnoses obtained by or determined by the experts, and that's how they would come to. So
you're saying that those persons never interviewed that particular person directly? So the people
they did.
They did.
So of course, by definition.
Okay, so everyone that you identify as having mental illness in your comparison groups that person was interviewed by a psychiatrist and then was provided a diagnosis?
No. So right now I'm just talking about the DSM field trials. Like right now I'm just focusing on the validity of psychiatric diagnoses themselves and kind of how.
Well, that doesn't make it valid. That just makes a doctor makes a subjective opinion based on established criteria. That doesn't necessarily make it valid.
No, what they would do is the DSM teams would decide on their criteria based on all the studies.
Yeah, I think I'm aware of that. I think I think my listeners are been well educated on this. We've had experts come on and talked about the DSM at length. I guess our question is when there's a database of mass shooters and there's conclusions that are being drawn that a mental illness, a category, does not equate to any increase in violence to the general population, which I think essentially is what you're saying, right? There's no
No, that's not what we're saying.
Okay. Your conclusion on mental illness and violence is what compared to your comparison groups?
So the conclusion was that 5% of mass shootings is directly caused by psychosis. And that is an overrepresentation because, as you know, psychosis, the prevalence of psychosis in the background population is about 1% to 2% depending on, what criteria you use, but it's certainly not 5%.
Okay.
So people with psychotic illnesses are overrepresented among mass shooters. There's no doubt about that. There's no doubt about that. But that's 5%. So that 95% of mass shootings are not related to mental illness. They're not directly caused by mental illness. Now, mass murder, when firearms are not used, is much more, to a much greater degree, caused by
All right. So
mental illness.
I'm a little bit confused because you're using the same word to describe psychosis. Psychosis is mental illness, but then I asked you, how do we define mental illness? You said it's broad, 40% of the public. So are you just focused on psychotic conditions, or did your research open itself up to anything that you could designate as mental illness?
All of them, yeah.
Okay.
All the major ones.
All right. So in listening to you on other news shows or other podcasts, it appeared that what you were trying to present was that we don't have really good evidence that suggests that somebody who is mentally ill is more likely to engage in violence compared to a non-clinical control group. Is that fair?
No, that's not true. No, definitely. People with major mental illnesses are at higher risk for violence. I mean, there's no doubt about that. And by major mental illness, we're talking about schizophrenia. We're talking about affective disorders, bipolar disorder, major depressive disorder, and of course, substance use disorders. That's separate. I mean, obviously, substance use disorders increase risk of violence. We know there is a slight increase of violence among people with major mental illness, not anxiety disorders, that's for sure, and not other sorts of conditions. We're talking about affective disorders and psychosis. There's no doubt about that. Now, only one condition, again, not including substance use disorders, increases the risk of murder in general, and that is schizophrenia to a very small degree, but it is significant, and that is only among very early episode people who are unmedicated. That's been shown, that's been replicated, there's no doubt about that. So that basically replicates or is consistent with our data on mass murder, in which we find that the only condition associated with any sort of mass murder or mass shooting is psychotic disorders to a small degree, 5%. When you compare that to the 1% to 2%, again, of psychosis among the general population, it's an overrepresentation. But that means that 95% of mass shootings, in this case, are not related to any mental illness, in this case, psychotic disorders. Now, again, if we're talking about other types of mass murder, the number jumps a lot. Again, it's about 18 to 20%. So 18 to 20% of other types of mass murder are directly caused by psychotic illness.
Okay. And are you coming to that conclusion from your database?
Yes.
Okay. But there was no interview of those shooters.
That's right.
So how are we able to provide a diagnosis when there's no medical evaluation?
Right. Well, that's the importance of the comparison groups thing. So you have descriptive data with like the 5%, the 20%, whatever percent. Those are what we refer to as descriptive data, which are always going to be limited when you use a sample rather than a population, which is almost never available in any type of research. And that's why we use both. We use the descriptive data, the 5%, the 10%, like the prevalence data, that's what we refer to as descriptive data. But we also use the inferential and comparative statistics. That's when you compare groups. That's how you examine criteria like specificity, temporality, those experiment in some cases. In this case, the experiment would be the clinical trial, like you said, which can't be done in this case. So that's why I mentioned the comparative data. So when you look at the comparative data, you see that, again, thinking about causation, one of the criteria for causation, that is, which is specificity, there is no specific relationship between psychosis and mass shootings. It seems like that actually prefers other types of mass murder. When you look temporally, you find that, in fact, while the prevalence per capita of mass shootings and all types of mass murder is increasing over time since 1900, the prevalence of psychosis being a cause for mass shootings and other types of mass murder over time is decreasing. So yes, the exact numbers, the 5%, the 25%, whatever, are probably a good estimation, but they can't be 100% accurate. That's impossible. That never happens in research. It'd be impossible to have that in any type of research. but it's helpful. But that's why we also use the comparison data. So you think about all that, and you think, okay, it seems like there's less of a specific relationship, and of course there are other data to suggest that. For example, then we have the data that we examined on. So we also examined our data on female mass murders. So we looked at female mass murders in particular because we wanted to, tease apart these relationships. So what we knew going into it was that the effect of mental illness, especially both psychosis and affective disorders, on women in regards to perpetrating violence is much greater than it is among men. The reason for that is because young men, like around 20, 25, are already very impulsive and tend to be more violent. Their base rate of violence is much higher, whereas the base rate of violence among young women tends to be much lower. So when psychosis or mental illness is involved, the relative change is much higher. And women, when they perpetrate mass murder, almost never use firearms. They almost always use some other method. So all these data together, again, kind of coalesce to the relationship between mass shootings and psychosis, rather, is very small. People with psychosis are probably overrepresented to a small degree, but again, the relationship was small. Again, if we're talking about other types of mass murder, then we're talking about more of a relationship.
Okay, I'm going to move on from the point that I was trying to make, and I think it was simply this, is when there's controversy around the validity of a diagnosis to begin with, and then the manner in which that diagnosis is provided as a variable that's being investigated, that if there's real methodological concerns with being able to draw any conclusions because it's difficult to ascertain whether that person legitimately even has those symptoms because you have no way of being able to reference that other than case reports from somebody else, which is highly biased, right? We're talking about, I think it's overwhelmingly news media and reports from law enforcement, correct?
It's exclusively media, law enforcement, and court records, exclusively, of course.
Okay, yeah. So there's challenges, with methodology to be able to come to those conclusions at all.
But that's a problem in all no research has 100% accurate, valid. There's no such thing.
Well, that's what science is, a search for truth. But when your scientific experiment is set up with so many flaws, it's even less likely that you'll be able to obtain any legitimate data.
Yeah, but we're, again, we deal with this by, again, using comparison groups. That deals with bias and confounding. We deal with this by examining multiple variables over time. So again, we look at things like, we look at the data in different ways, temporality and specificity, all these sorts of things. And again,
Doc, I know you don't have to go through that again, but it always starts with a foundation. Is you have to have an established construct, right? You have to have, that's got to be observable, that has to be measurable, and that data has to be collected in a way that allows for us to try to confirm that to the best that we can, right? So if we're gonna, measure the presence of a virus, right? We need to be able to observe that virus. We have to be able to measure that virus, and then we'd have to be able to compare it to someone who doesn't have a virus, for example. That already is not occurring when you're slapping on a diagnosis and broadly saying it's mental illness, because you can choose anything to be mental illness then. When 40% of the American public can be identified as having mental illness at any time, that broad category allows an umbrella term for you to say anything with subjectivity is a mental illness, and then look at a comparison group and say, well, I'm going to choose not to provide a diagnosis there, even though you may not have enough evidence to be able to do that. Is that fair?
Well, I hear what you're saying. I will address this point. So I just want to make sure we don't conflate the two issues. One is the limitations of the research. I understand you're talking about the validity of psychiatric conditions. I want to address that. That is the second point, though. We've discussed the validity of the research itself, the limitations, bias, and all those sorts of things, so I won't mention that again. So yes, now definitely let's get to validity of psychiatric diagnoses. We kind of mentioned the DSM, that they compared the gold standard with the criteria. This was the point of the field trials. And they determined things like sensitivity, specificity, negative, positive predictive value. They would determine these statistical parameters, and usually they're in the 80% range, which is considered acceptable.
You believe psychiatric diagnoses are scientifically valid constructs?
Definitely. So, and this is the point I want to get to. I understand we need to discuss this. This is the point I want to get to. So that's just the DSM. So generally, a diagnostic measure is considered relatively valid or clinically useful when it gets to about 80% in terms of sensitivity specificity. So that's
I argue against that. That's ever been achieved with a psychiatric diagnosis.
Well, I hear it, and that's what we're going to discuss for sure. I hear you, definitely. No, I appreciate the back and forth, and that we get to discuss these important issues. But that's just in general. 80% is about kind of the criterion or line we use in all of medicine to determine when a diagnostic test in particular is considered, valuable or not.
Then let me challenge you on that. So, what is the diagnostic test that allows you to observe that in bipolar II disorder?
What's
the test? What's the how is that evaluated? How is bipolar II a valid construct? Like, so how will a physician be able to take the time to be able to observe, evaluate, and identify that with accuracy?
Sure. Oh, well, I'm referring to the DSM criteria. So now I'm just referring to
So do you see how circular this gets? It becomes circular reasoning, right? You end up saying, well, a psychiatric condition is valid. Why? Because the DSM exists.
But the DSM is based on something else. It's based on a gold standard, and that's how they identify.
You believe that? You believe the way that the DSM is constructed is gold standard science. Be honest. There's a lot of people listening.
Definitely.
Because I think a lot of the people who actually were chair people of the DSM across very different, all of the different editions would clearly argue against that. Like Alan Francis, for example.
That the DSM is
scientifically valid. It was never meant to be that. It was never meant to be the identification of clear, identifiable, discrete medical conditions. It was always attempt to try to the best of their ability, and they failed horribly, to try to cluster symptoms together for the purpose of research, classification, and communication. And so it's not explanatory. Like, someone has bipolar disorder, no one can say why they have bipolar disorder. Someone's depressed, the diagnostic criteria for major depressive disorder doesn't say why that person is depressed. It's just a label, and it's poorly constructed label.
Yeah,
it's arbitrary, right? I mean, it really is arbitrary.
I would disagree.
You would disagree?
I believe the DSM is valid. So we've tested, and so this brings me to my next point. So in terms of statistical parameters, the DSM, again, the criteria, especially for the major psychiatric conditions, reach about that 80% threshold. So, but you're saying even with that, these aren't valid, medically valid, or maybe biologically valid, or
are you aware of
conditions?
Well, both, right? First of all, I don't even believe they meet the very basic level of scientific scrutiny to say they're a valid construct, because there's too much diagnostic overlap. I mean, it's very difficult for someone, even if you're going to use the diagnostic criteria, they're all experiencing multiple things amongst a continuum, right? And then you only get to, if you're going to use observation, you're only going to use someone with observation in a very short, discrete period of time. So, for example, if I unfortunately had to come to this podcast today on like 2 hours of sleep 2 nights in a row because my kids are older, but let's say I had a crying baby and I'm sleep deprived, right? And I'm irritable, and I lash out at you because, I don't believe some of the statements you're making. It could be could be easy for a physician under those circumstances to draw conclusions that meet some threshold in a DSM. Increased irritability, decreased need for sleep, behavioral manifestations of bipolar II. One might say he's hypomanic. There's no medical observation. There's no brain scan. There's no blood test. There's nothing with DNA. There's no serum levels conducted. It's just a subjective interpretation of human behavior without understanding cause, right? So you're almost entirely going to determine the nature of that based on my own self-report, right? And then, which is very challenging, because then you're identifying somebody as like mentally ill, so somehow they're compromised, but then you're relying on the validity of their report to even make that such a diagnosis. So there's all types of concerns empirically. And since those diagnoses have so much weight and so much power in the medical system, in the legal system, for something with such great subjectivity, that creates tremendous degrees of problems in the system. And so, are you aware of Koch's postulates?
I'm sorry, I'm not.
Yeah, I mean, this is something that's really important to make for an empirical threshold, right? So Koch's postulate is very simple. Is there a specific biological abnormality? And it must be present in all cases. So if you're observing something, it must be present in all people who have that condition and then not present in people who don't, right? This abnormality must be measurable and identifiable through some form of objective testing. There must be a clear causal mechanism, right? Linking the abnormality to the symptoms, and it's got to be reproducible, right? So those are four kind of postulates. If psychiatric diagnoses don't meet any of them, right, aren't we just saying it's our best way of trying to make sense of complex phenomenon versus saying, you know, it's this condition and there's 80% sensitivity and trying to communicate to the public that there's something legitimate and valid and scientific about it. And that's my major concern. I'm going to let you speak in a second.
Sure.
My major concern is, are we honest with the public in the way we communicate scientific findings? Are we honest about the limitations of that? And were we clear in what we're saying? I don't know. We're doing the best we can, but it certainly doesn't meet some standard. And can we communicate it to the public in a way that I think meets a bottom line threshold for informed consent and medical freedom? So I'll stop there.
Yeah, well, there are a lot of points. I'm glad that you brought them all up, and I'm happy to address each one of them. So with regards to the DSM and the criteria, so there's this 80% level. That's considered acceptable within medicine. Now, the next point you brought up, I think, was about like how they're applied, whether they can be applied like within a session. So we, psychiatrists, psychologists, and all other mental health clinicians, do their best to examine understand the criteria, the 9 or whatever, depression, whatever. Over time, they don't ask about how someone's feeling after one day. They, for example, for depression, make sure that the person is experiencing 5 of 9 symptoms for at least 2 weeks, etc. They obtain collateral information. They observe them over time, and eventually they develop a relationship with them, and they might see them for years. And that's obviously less common. But please go ahead.
Yes, I mean, my first thing is you understand that criteria is arbitrary. What makes something a condition in 2 weeks is an arbitrary definition, and that standard's been lowered over time. Are you aware of the work of Charlotte Silverman?
I don't know.
She's an epidemiologist, or I don't think she's currently living, but she wrote the book, The Epidemiology of Depression, I think early 1960s, where we went historically and identified, the prevalence rate of depression throughout various decades in the early part of the 20th century. And so when you're talking about the identification of what was described as melancholy or depression was less than 1% in the population of the United States. And the people surveyed, the overwhelming majority of people who did experience that would achieve what's called natural recovery. So it was a discrete period of time they'd be able to overcome that. And it was almost always related to events in their life, right? So I'm depressed because I'm struggling financially. My wife left me. I can't get work, real legitimate conditions that would lead people to feel pretty bad and relatively temporary, right? So again, there's probably a threshold to be able to identify someone as a severe psychiatric condition that may be required professional help back in that period of time. But over the years, we have expanded the definition of what is mental illness. We have slowly decreased the idea of what is normal. And now it can be widely applied very, very quickly. Now, you absolutely spoke about what is the most ethical way to be able to provide a diagnosis, even under the current conditions of the DSM, which would be get collateral information, don't make a diagnosis haphazardly or quickly, observe that person over a period of time, an empirical way, and I'm right there with you. But in clinical reality, that is not what is happening. You said something very interesting to me when you came in here about Bethlehem. What did you ask?
I asked what sort of patient load you have.
Yeah, was it hard to find clients, right?
Oh, yeah, right,
Yeah.
right.
And
Just to be clear to everyone, I'm from New York City. It's the only place I've ever practiced. Bethlehem's smaller than New York City.
of course, yeah, in comparison, I could see it. But it was maybe unaware what's going on in our communities across the country. The overwhelming amount of people that are being placed on psychiatric drugs are doing so in primary care settings,
Sure.
where primary care docs are seeing these people for less than 15 minutes. And do you know how they're making diagnoses of depression, including children and teenagers?
I'm not sure. Please tell me.
A quick screening measure.
Oh.
I can't even remember the name of it. You're probably more aware of it. It's a
PHQ.
PHQ, right?
Yeah.
Right. Developed by Pfizer initially, yeah. Really to push more drugs. So we're getting an overwhelming amount of people on these drugs based on really quick screening measures in 15 minutes. Additionally, we're communicating, which is a very strong marketing push that dates back to the early 90s when SSRIs were first brought to market, about depression in a certain way. So we're influencing the collective consciousness. You can take this drug, you'll feel better regardless of cause. And so it's pushed a multi-trillion-dollar market. We have over 20% of adult females are now on SSRIs. So my point being is that when you reduce the threshold of a condition to enter into the realm of normality, what is normal for human beings to experience, you're going to increase the amount of people who identify as mentally ill, which goes back to my argument previously and why it's problematic research, is that when you are able to identify so many people with mental illness, and without a doubt this fuels an entire pharmaceutical industry as well as a medical apparatus, that those conditions that identify those symptoms and the thresholds which have been decreased over time aren't based on science. 2 weeks is arbitrary. There's no field study that says, okay, 2 weeks someone's severely depressed, but 10 days they're not, 3 weeks they are. You're just continuously lowering it. Same with the 5 out of 9 symptoms. Like if you experience 5 of these 9 symptoms, regardless of cause, you can obtain the diagnosis. This is clearly trying to increase the number of people who identify with the diagnosis. And that's not scientific. That's political. That's like industrial manipulation.
Right. I hear you. You bring up a lot of points, and I want to be able to address all of them, and I certainly can address all of them. I'll suffice it to say, for the sake of brevity and just to make sure I can get to everything, so the criteria have been validated. If we're talking about phenomenologically, meaning symptoms and time, the criteria have been validated, as we've discussed. This 80%, the DSM field trials, I'll leave it at that. Now, that 2 weeks time period, that's been pretty stable over time, I think. Now, about the...
What do you mean by that?
Like the 2 week criterion for major depressive disorder, I mean, that goes back many decades. I'm not sure that's changed much over...
Do you understand why the threshold would be decreased to 2 weeks?
Do I understand why? I mean, you told me why you think other people might want to, but I think I might be able to answer your question, though, by saying I think maybe one point we'll disagree maybe about the most is, or maybe two, is one, we have other evidence. This is kind of how I was supporting our results with regards to the relationship or lack of relationship between mass shootings and mental illness. And that's there are other types of studies and other data that are consistent with our data. So we have neurobiological data which support these phenomenological or diagnostic constructs.
Go ahead.
And we have pharmacologic data which support these constructs.
All right, let's start with the neurobiological data.
Sure, and this gets to like the criteria. And these get to the Koch's postulates, which are kind of similar. So the neurobiologic data, so for example, for depression, for major psychiatric conditions, the data are very clear.
No.
I know we're going to disagree about this.
When you say things like data are very clear, that's where I feel like we'd be misleading the public. It's okay for you to say, I believe this exists, and you might want to cite it, right? Because then I can include it in the show notes, and then we can evaluate it. But I don't think you're being completely transparent when you say the data is clear when it's clearly controversial, very controversial. I'm okay with you speaking your position, but I'm very careful on this podcast by communicating things that we don't know to be true.
We would disagree about that, and that's okay. It's totally okay to disagree.
What are the biological markers then for major depressive disorder that we use to make that diagnosis?
So, those are two different things. So, to make a diagnosis is different than knowing that something is biological in nature or understanding the neurobiology. For example, most medical conditions, even if they have a biological diagnostic marker, let me back up. We don't necessarily understand the biological cause of most medical conditions, even though in many cases we have a biological marker. Say, so for example, blood pressure. I mean, there's the diagnostic marker is different than, for example, the biological cause, which isn't even totally understood. So it's just, this relationship, this is just how medicine works. We can't understand everything we're learning.
But that's a biological marker that one can evaluate in a medical practice.
Right.
What's the biological marker for depression?
But those are different, just to be clear, and I'm going to get to it. I'm just saying that just because we don't have an adequate diagnostic marker, which actually is not the case, we actually do have diagnostic markers for most conditions, they just don't reach the statistical parameters, sensitivity, specificity, all these sorts of things, aren't better than phenomenology or the DSM criteria. That's why we don't use them. But we do have, we could use any of the neurobiological markers as diagnostic markers. It's just that, again, they don't perform better than phenomenological criteria, like the DSM criteria. And then you have to consider cost and risk and those sorts of things, which are very important. And again, this is common among medicine.
But what you said, you said neurobiology.
So then
what's the consistent biological marker found in depressed individuals?
So there are many, but I think the one that most people think about or have heard about, and the one with which I'm most familiar, because this is one of my areas of research, is the monoamine hypothesis, or the monoamine markers of depression. Because obviously, also I deal with schizophrenia, so we talk about primarily dopamine and glutamate. But in depression, as we know, depression is reliably and validly related to, again, it is complicated, but lower levels of monoamines, primarily serotonin, dopamine, and to some degree.
So the whole chemical, you're kind of going to talk to me about the chemical imbalance theory of depression.
That term is used. It's the monoamine hypothesis, the lower levels of serotonin and dopamine. Again, it's a little more complicated than that, but yes, that is right.
Are you aware of the umbrella study in 2022 that was put out there?
Moncrief.
Yeah, Joanna Moncrief.
Sure.
I guess one of the things that is challenging to me is that the idea that depression is related to low serotonin or deficiencies in serotonin was never reliably proven up to the point of when we pushed on antidepressants, and it's never been confirmed. The umbrella.
It has.
Well, there's many people in your field who completely deny that.
So I want to be clear. I know we're disagreeing. It's okay, but I want to be clear. There's virtually this isn't controversial in the field. I understand that
it's quite controversial. I have a very large platform that is now in the top 0.05% related just to these ideas. And I've had plenty of other psychiatrists on here where we've talked about the same thing. So what do you know about the Moncrief study 2022, the umbrella study on serotonin?
I know it well. I've read it multiple times. I'm familiar with it.
Can you tell my audience about it and why you dispute it?
Sure. Well, first of all, again, I will very specifically. I will say, we look at reproducibility among studies. This is one study again, and this was a. I think that you called it, and it's correctly called like an umbrella review. It's actually a review of reviews. Number one. So one potential limitation of reviews of any type of review is that even though meta-analyses and systematic reviews are considered maybe the highest kind of the most rigorous type of evidence, they have to be conducted in a certain way. So, and I'm not saying that Moncrief did not conduct hers in a certain way, but I will explain. So with meta-analysis and reviews, say a findings, for example, low serotonin in depression. And I can explain more about what low serotonin actually means because it has more to do with serotonin receptors, but either way, and transporters. basically those the low serotonin, the findings of low serotonin and low dopamine, but low serotonin are primarily observed in younger people, earlier in the illness, not on medications, etc. So you have a few of those studies, but then you have a lot of studies in which, like PET studies or studies examining serotonin levels in people with depression and people who have comorbid disorders later in their illness on antidepressants. So if you put all of those together, you'll see nothing, because you'll have like a handful of studies that are positive or show that finding, and then you'll have many more that don't, because they weren't they were different than the other studies. That's how those things can
just to be clear about their position, they say there's no relationship. I mean, it's a complicated neurochemical that impacts the entire body.
They didn't say there's no relationship. So this is what I'm getting to. I'm going to get to her Moncrief's specific findings. So if you look at the results explicitly say that there is a relationship. In academia, in research, the most important thing is our credibility. So that's like the reliability, the validity, our ability to collect the data to put in the results and methods what we did and what we found. And then we can interpret the data in different ways, and that's totally okay. And that's what Moncrief did. And I think they very credibly reported the data, both in the methods and the results. So when I tell people, when I learned how to read research studies, and when I kind of help my mentees learn how to read research studies, I always tell them, just read the methods and the results. So if you look at the results, they say there's a relationship. And then in the discussion, they say we're not convinced by the evidence, and the evidence to us aren't consistent. But in the actual results, they say there is a relationship, and that's specifically especially with regards to the PET or positron emission tomography data, examining relationships between serotonin, I believe this transporters and depression.
Okay. I don't want to speak for Joanna Moncrief, but would you be willing at any point to have a discussion on the podcast with myself moderating it with the two of you, so you can just
with
Joanna Moncrief? Yeah.
I mean, I'd be happy to. I mean, I'd be happy to. That'd be fine. I mean, but that was her. Those were her.
No, I think I think you might be misrepresenting her position, and I think the burden.
No. Her position was that the data aren't consistent or convincing. But
exactly.
In the results, she reported a relationship. She mentioned it was a small, weak, but it was a relationship.
Yeah, I think and I don't want to speak for her, but I think if she was communicating this, she said, "Listen, when you identify a causal relationship, like low serotonin equals depression, and that drives the mass use of a pharmaceutical that targets that, where we don't have I can get into the long-term data problems, the concerns with this, even in acts of violence. And there's no definitive proof that anyone who has a severe major depressive disorder has deficiencies in serotonin. We can't communicate that. Like that's an invalid way of being able to describe a relationship. It's on the burden of proof is to prove definitively or clearly that there's a causal relationship, because we're targeting it with a drug."
Well, so we can't prove anything like with 100% certainty. We're always in a gray area. That's just how science works. So again, there are other evidence connecting serotonin and depression. So, and we just discussed the Moncrief review. Only what was reported in the review. I mean, I don't know what Moncrief herself says, but I know what was reported in the review, and that's just kind of what I shared. Now, and again, that's just one paper. Now, if you look at the other papers, you focus on the studies done in people with early depression, less comorbidity, especially less personality disorders, no substance use, not on antidepressant medications. It's clear you have lower levels of the serotonin transporter, especially in kind of midbrain.
No, I don't think that's clear. And prior to 2020, I did a deep dive into this to try to create a position statement for my practice, just because we were seeing so many young people placed on the drugs. And, I haven't been able to see anything that was a strong scientific study proving that hypothesis. In fact, there's just a lot of professionals in your field, psychiatrists, prominent psychologists, that have moved far away from that idea in particular, right? So it's fine for you to say, you still believe that there's some validity to that and take that position, but we have to be honest here about how disputed that is generally in the field, and how controversial this is. And there's a lot of data that, contradicts those statements. We cannot say it's clear, right?
Right. Well, that's my interpretation. But I am being honest. Those are what the data show to the majority of academic psychiatrists, for sure. I mean, certainly researchers within this field, within that kind of the field, the scholarly kind of group within which I tend to work. Do
you think you might be in a bubble?
Well, my
like Columbia University, New York, kind of the epicenter of groupthink, right? I mean, it is certainly tough because you know John Ioannidis is at Stanford.
Sure.
Yeah. So I mean, if he's here, he's going to be arguing against you, right? That there's this clear chemical imbalance theory of depression, and
has he reported on that? I don't know.
Yeah, and he's discussed it at length, and in fact, he argues that about 85 to 90% of the research that physicians and academics rely upon is unreliable.
Oh, I know he said that.
And do you know Richard Horton, who's the editor-in-chief at Lancet, says the entire medical literature is pretty much encompassed by small sample sizes, tiny effects, invalid analyses, and conflicts of interest. And then there's Dr. Marcia Angel, who's a former editor-in-chief at the New England Journal of Medicine, who says simply no longer is it possible to believe much of the medical literature on these clinical conditions published as can be relied upon because of the poor science that's being published and the conflicts of interest, right? So when I bring on experts and they say, I think it's clear or the research shows, then they're never actually referring to the quality of that research, right? And it might be exactly the research that's funneled to you, in the epicenter of all this. I think New York City is the epicenter of this. I mean, you're relying on media too to create credible research. Like media reports are what you're using to communicate scientific findings to large-scale organizations or media outlets like Fox News, for example, right?
Right, sure. Yeah, let me be, so again, sorry, go ahead. I don't want to cut you off, I apologize. But I will address your points.
Because it filters out to popular culture, right? And we start throwing out these words, chemical imbalance, mental illness and violence, and we start making all these assumptions when it has not met even like basic scientific thresholds, and there's large degrees of discrepancy and debate, and that's what science is. It's a search for truth. Like, I don't even believe we have good evidence that the brain emits consciousness.
That's that's a completely different question. I can't address that question. I'm sorry.
I know, but like even coming out of, there's good science coming out of Columbia.
I don't know that.
Yeah, so I mean, if we haven't been able to measure that, right? Like if there's no brain activity and consciousness exist, now we're going to reduce the complexity of the human experience, like mood and depression, to like one neurochemical that we've been able to identify, something as complex as serotonin. It almost seems like ridiculous to even talk about it. Like, what are they going to say 50 years down the line, looking back at conversations like this?
I hear you. But now again, I there are a lot of things to unpack here. We're combining too many things. So again, that's with the assumption. I know this is your premise that things like depression and schizophrenia aren't, categorical biological conditions. So with that premise, I understand what you're saying, but
I think there's biological effects. Like I don't dispute that, obviously.
So let me see. You said a lot of I can't address consciousness. Oh, about the bubble. Columbia's in a bubble, but I think the bubble in which I live and work encompasses about 98, 99% of academia, of neuroscience, academic neuroscience, academic psychiatry, for sure.
I asked a neuroscientist once. I said, on a scale of 1 to 10, 10 being like we have full understanding of the human brain and consciousness, 1 being the brain is still a very, very mysterious organ. Do you know what number he identified?
Yeah, it's like 1 or 2. It's very small. There's no doubt about it.
Yeah, so it's so important, Doc, that we're able not to speak in certainties, but to be able to identify where debate exists, where questions exist, and be very mindful of saying things like it's pretty certain, or it's proven, or there's agreement. I can absolutely assure you that there is not agreement on the subjects that we're talking about today, but there may be an agreement in that bubble that exists for you in academia, but globally it certainly doesn't. And that's why I would love for you to do just a long form discussion with like Dr. Joanna Moncrief, who is doing the research on there, who speaks to this, I think, in a nuanced way. I think she's very credible. She's better to speak for her findings than I think either you or not I are. So if that opportunity arises, I mean, that's great for the general field. It's great for the American public, because then we can really have nuanced, long-form discussion where there's debate. I think the problem that's happened in our culture is that debate has been limited and things have come in from like a bubble, and there's authority bias. And we're just supposed to sit back and say, okay, well, a perceived authority says it's clear, right? And so you're a perceived authority, right? You're an academic at prestigious university. So we can just sit back and say, okay, you're the expert. You don't have to necessarily cite any research. You don't have to talk about the details of that, the methodology or the strength of the evidence. You just have to say it's proven. And you see where that's problematic.
Well, I hear you, but all I've been doing is talking about method and data. That's all I've been doing. I mean, that's exactly what I understand that I'm considered an expert and authority in these sorts of things, but I'm only talking about data and methods. That's completely what I'm talking about. Anyway, but now, so we can disagree about a lot of things, including the bubble. So you mentioned the 85% number. Oh yeah, the 85% about research. Yeah.
That's John Ioannidis'
No,
number.
it's probably higher, but that's what I'm talking about. For example, the serotonin finding is in the 15%. Sure, I've read any of my reviews. I've conducted reviews on hundreds and hundreds of studies. I published one review maybe 3 or 4 years ago on experimental medication trials in schizophrenia. Yeah, I mean, even when studies are positive or negative, it almost doesn't matter. I mean, basically out of like 500 studies, not one of them ended up leading to anything, even though many were positive and many were negative. I mean, that's exactly the case. The serotonin finding, and I'll leave it at this, and I know we disagree, and it's okay. The serotonin finding, for the clear reasons I mentioned, is in that 15%. But the reason we know that is because we don't just have the positron emission tomography and SPECT studies, like the brain imaging studies, which again is what even Moncrief reported. She also reported the tryptophan data from tryptophan depletion, and then I think she reported 4 specific areas. I think the fourth was tryptophan depletion. I think the middle 2 were like imaging, and then the first one was on, I think, serotonin levels in neuropathological and biochemical samples, like brain biopsies and then like CSF levels, et cetera. And I think she found that the first and the fourth were completely negative, but then there was association in the second and third, the brain imaging studies, like just transporter levels and whatnot. But we also have other data that are consistent with the brain imaging studies, suggesting this serotonin deficiency or chemical imbalance. So now we come to the medication studies. So the question is, do medications work? So a premise of a lot of people is that medication, the selective serotonin reuptake inhibitors in particular, don't work. They cause a lot of side effects, et cetera, but they don't work. So again, going back to the 9 criteria or 8 causality criteria, experiment or reversibility or whatever, specificity would be one other criterion. So if a selective serotonin reuptake inhibitor were to be effective for depression, that would be kind of consistent evidence of the serotonin imbalance theory, probably. Would you agree?
No, I would not.
If they were to work. I do think they work, but if they were to work, wouldn't that kind of support the theory?
You'd have to define work. So let's say I create a drug that, and again, they're drugs, not necessarily medicine. They're synthetic chemicals created in a factory. They influence, brain function, consciousness, number of things, right? So let's imagine.
They don't affect consciousness. I mean, maybe some drugs do, but consciousness, as we understand consciousness, they don't affect consciousness. They affect a lot of other things, but not consciousness.
Oh, I would debate that.
But what do you mean by consciousness? Do you mean like they can make people tired? If that's what you mean, well, yeah, of course, some of them can do that.
No, they have been proven that they've induced psychotic episodes.
Well, I'm not sure that's the case, but that's not the case. But that's not if that's what you mean by consciousness, if anything that happens when one is
Well,
awake by consciousness, then I
no,
guess,
let's
yes.
identify. Well, I guess we have to identify what consciousness is. Our
I mean,
perception of reality,
Perception of reality.
our understanding of reality, right, is a form of consciousness. Our awareness.
That's a broad definition. I don't know. I mean, certainly SSRIs definitely have effects on the brain. I guess we'll leave it at that. Because I don't know enough about consciousness. I shouldn't go down this road. I don't know enough about it.
So, just very simply, if I create a drug
Sure.
in a factory that can induce some emotional blunting or sedation, and then I create a measure that accounts for that as if it's working, well, then the answer would be yes. So it's just a little bit too complicated, because if you make up the disease, right? So if you arbitrarily identify the symptoms of a disease and you don't have any other biological markers to observe it from, so it becomes more subjective, you just create a series of symptoms. You can set up a trial very easily by creating an outcome measure that is going to fit the effect of the drug. And of course, as you would know, when there's a randomized clinical controlled, placebo-controlled trial, that if you know you're taking the drug because it affects you psychoactively, then it breaks blind. So you're going to see some increase in response, or people identifying that they've taken the drug. There's so much interesting research I can get into. But it seems like you and I have a difference of opinion on what works and how effective the drug is, or how it's proven to be effective. Is that accurate?
I think they're effective. There's no doubt about it. There's no doubt about the fact that they're effective. Not for everyone, absolutely. They have a number needed to treat of about 7, which is among the best in medicine. Let's say very good in medicine. Stimulants have basically the highest number needed to treat. But SSRIs have a number needed to treat of about 7, which is considered very good. Psychiatric medications in general have a number needed to treat of about 7, usually, which is very good. Again, a lot of points. I can address all of them. I'm sorry if I'm missing points.
I guess we have to actually, you seem very clear that you believe an SSRI is proven to be effective, and that's exactly how you're taught. Like,
it's not a belief. It's based on the data.
It is absolutely not.
I know
well, you and I are looking at the same data. Yes. My guess is I've probably looked at more data on this than you have, including looking at data from Freedom of Information Act, from court trials. I've done a deep dive. I've talked to government officials. I've talked to other psychiatrists. I've talked to experts around the world. Here's my conclusion, and you can debate this or not. If we look back at the original trials about how an SSRI came to market, Prozac, 1987, right, was when it first came to market. Are you aware of what happened in those clinical trials and what happened politically to get that just to market?
Probably not everything, no.
Okay.
It's not necessarily relevant, and I will explain why, but feel free to share.
How can clinical trials that are actually conducted by the drug companies themselves that led to the approval by the FDA not be relevant?
Because we have many other types of data, again, supporting the serotonin hypothesis.
But they're not good studies, which is exactly what I was kind of referring to you when we're talking about the totality of this research. When it's poor, we can't say that proves it. We need valid long-term evaluations.
But we have them.
Okay.
We've had these medications for 70 years.
Are you aware for the market prescribed to the United States, SSRIs, it's post-1987.
Well, SSRIs are just a form of medications we've had since the 50s, like tricyclic antidepressants. They're just another
They
version.
weren't successful then either, Doc.
Tricyclics?
Right.
MAOIs?
Yeah, exactly.
Monoamine oxide?
Yeah. I mean, historically, if you look, first of all, a very small percentage of people that we would prescribe them to, very small, come with a range of problems and not a huge improvement in functioning. And there's a reason why the SSRI revolution came. It was because of those failures.
No, it was because the medications have lots of side effects.
Failures.
Well,
I mean, that's quality of life. We're talking about people with emotional conditions like depression. Like, what you call a side effect is a strong adverse reaction that sometimes makes people want to kill themselves.
No, antidepressants do not make people kill themselves. Again, this is I want to address all these, but it's so hard.
Doc, this is in the literature. I don't even know how you're making these statements.
It's not in the literature. I know we need to address. I want to address each one of these. It's a great points.
There's a government black box warning, okay, just for under the age of 25. And that is way too conservative because there's been data on adolescents that shows a 4 to 6 fold increase in suicide in comparison to the placebo group. We have a government black box warning for inducing suicide. We have international drug regulatory warnings throughout the world, right? For increased suicide and violence. So why would they put those warnings out there if it didn't exist?
These are a lot of very good points. I didn't necessarily want to go there, but we can go there. So the data, so if you go to the Moncrief article and you read some of the comments in response to the article, everything will be summarized there. SSRIs, antidepressants in general, none of the antidepressants increase suicide. Now there are...
Do you know how many people I've met personally that talk about that exact causal relationship? Are they lying?
No, we need to talk about the data, though. We need to focus on the data. So the data are clear. Antidepressants decrease... I'm not familiar with that book, I'm sorry. The data are clear. Antidepressants decrease suicide. The data
You're doing it again. You're on a popular podcast and you're saying the data is clear. I'm fine with you saying I debate your premise. You can't come on a show like this and say the data is clear when your own field is going to dispute that.
No, but I haven't finished my statement. So to address the black box warnings and what people perceive as the increase in suicide, it's not an increase in suicide for which there are equivocal data. The equivocal data are for an increase in suicidal ideation. There are no data suggesting antidepressants increase violence. So the black box warning is only about suicidal ideation, and they lump behaviors, not completions. So there's no doubt that antidepressants decrease suicide completions. They don't increase behaviors, but in the black box warnings, and what people do is they sometimes add behaviors to ideation because there are definitely some studies showing that there's a relationship between SSRIs and increased thoughts or ideation. There are those studies. Overall, the data are equivocal. Now, for those studies like what we call registration studies, in the package inserts, like for fluoxetine, for example, do you know how many suicides there were in those trials?
They withheld the data. They removed them from the data. Are you aware of that?
There was zero.
Because they removed them and did not report them to the FDA.
There were zero.
1990. No, there were not zero. They were actually. I want you to read the book Medication Madness: The Role of Psychiatric Drugs in Cases of Violence, Suicide, and Crime. Dr. Peter Breggin. I'm actually going to his house next month to be able to interview him. He's a psychiatrist. He's been a medical expert in product liability cases, and he's been able to obtain through the discovery process private memos, as well as the data from the drug companies that has proven that when people became suicidal on the drugs, they either removed them from the final data count or they gave them tranquilizers. So 1994, there were so many lawsuits against Eli Lilly that a federal judge in Indianapolis combined 160 cases into a consortium called the Multi-District Litigation. And through the discovery process, Eli Lilly had hidden data that Prozac caused mania in patients who had never been manic previously. Additionally, the stimulating effect was so pronounced in a portion of their trial patients, Eli Lilly's top scientist, Ray Fuller, without informing the FDA, signed an in-house memo to prescribe tranquilizers to patients who were demonstrating a stimulating effect that ranged from hypomania to psychosis and akathisia. And akathisia appears to be a precursor to people wanting to kill themselves. So when I've either done evaluations myself or had people come on the podcast who've been able to describe what happened after they were prescribed the SSRI, they describe these very experiences, including David Carmichael, who killed his own son after being inaccurately prescribed Paxil. And due to the scientific data from these trials, you're seeing these perpetrators, these homicide, these people who are on defense for homicide. They're being acquitted based on this data. So this was not reported to the FDA, and the drug would have never been approved if it was. The Westbecker case is another great example. Peter Bregan was an expert witness. He reviewed hundreds of published studies concerning Prozac and an innumerable large storage boxes of sealed Eli Lilly memos, letters, and studies concerning the development of and marketing of Prozac, some which were obtained through FOIA requests. That's Freedom of Information Act. And the discovery process. So unless you're looking at that data, you can't come to that conclusion and say zero, because after Joseph Westbecker's psychiatrist introduced Prozac, he exhibited psychosis, shot 20 people, killing 8, and himself. We see a number of cases across the world. 2001, Wyoming jury awarded $8 million to a family after a nonviolent grandfather went on a shooting rampage 2 days after starting an antidepressant drug.
Roger.
You know, you see this all over the case reports, and I'll just refer to the medical expert who's documented this. So it's fine for you to say, well, we've got alternative data. I've got another opinion. It's just we can't say it's clear. That's just not accurate and not fair.
I hear you. I'll stop using that word, but we have many other studies since the 90s or whatever. Again, I'm trying to go through all the data. We have many other studies showing that SSRIs, antidepressants in general, decrease completed suicides. And so now, again,
there's published studies that also say that that is wrong. That's inaccurate.
Not completed suicide. Suicidal behavior and ideation. Yes,
but you understand the difference. In a study, those people are being monitored, so it's difficult to complete. Now we're also trying to extrapolate this.
It's actually the opposite.
No, you're being monitored in a study.
You're being.
So when
Oh, you mean complete suicide?
Yes.
I see what you're
saying. So like let's say you're in a trial, you take an antidepressant, you want to kill yourself. You're being monitored very well, and you have a physician or a researcher to report to as soon as that happens. What we have to do is we have to try to extrapolate what does that mean then in real life, because that's not what is happening in our communities.
But the data in the clinical trials
demonstrates increased suicidality.
So in some of them, that's right. So in terms of just
all major ones, even ones from our government.
I know. Let me just
STAR-D study.
In terms of just completed suicide, the data support that SSRIs prevent in terms of completed suicide. I'm talking about clinical trials. Now, in terms of suicidal ideation,
how do you determine that? How do you determine that something prevents something?
Well, I mean, that's the point of a clinical trial.
No, because the clinical trials do not report that.
Sure.
So there might be some real-world data that you're referring to. How do you determine in a trial that a drug would prevent a future behavior?
Well, if there are less of those sorts of behaviors in in this case the SSRI group compared to the comparison group,
the placebo,
or some sort of active comparison.
But a placebo group, right?
That can be a placebo.
Well,
that's always.
Well, if you're comparing it to another drug, then you can't make that determination.
No, it can be something. It could be therapy or something like that.
Okay.
It can be some sort of active comparator.
Okay.
It could be an antipsychotic.
And so why then will we have all these international drug warnings, including our own country?
Yeah, I mean, they're being conservative.
Being conservative,
so with regards to
but if there's no data and you're saying that a drug would prevent it,
we're talking about multiple different things.
Why would there be international drug warnings? Why would there be a black box warning?
Well, that's what I'm clarifying. So now we're done with completed suicide. So suicidal ideation and behavior, especially suicidal ideation. There are lots of studies showing or suggesting that antidepressants increase suicidal ideation. There are lots of ways to understand this. First, if you look at all the data, a lot of us think that those data are equivocal. So there are a lot of studies that suggest that they decrease ideation, but a lot of studies suggest that they increase ideation. So it was safe to put a black box warning there. Another way that people think about it is that, and again, this is with the understanding that antidepressants, or the data showing that antidepressants decrease completed suicide. There are also the data of which you're probably aware, or our understanding of how this works, that there are multiple different types of suicidal ideation. So when people are close to wanting to take their own life, they won't report suicidal ideation. As they improve, for example, when they take an antidepressant, for example, in a clinical trial, they will not want to act on their suicidal ideation, and they'll be more likely to report it. So that's number one. And number two, I'll go back to kind of what you mentioned about how people are monitored more or less. The people who are sicker end up, especially if they're on an antidepressant medication and experiencing more side effects, which we will get to, because of course SSRIs have more side effects than placebo. They'll be seen more often, and they'll have a chance to report suicidal ideation more often. And that, again, also, as you know, in many of these, especially the registration studies, the suicidal ideation was not systematically assessed. It was just kind of reported. So that's kind of how we understand that. Now, there are also, just to be clear, there's no black box warning for violence or homicidal. There's no black box warning for that.
In our country, other countries there are.
That might be the case.
Yeah.
I don't know.
The EU, for example.
But there are no data suggesting that antidepressants increase, certainly not murder or homicide.
Because they don't study it.
But then how could they know that it increases violence?
From clinical trials, case
but then
reports.
They do study it?
They don't report it. So this is like probably the largest problem when it comes to our research literature. It's selective reporting. This is what happens when you have a drug company that's going to make billions, if not trillions, from a drug. That once they start observing things within their drug trials, they're incentivized to try to protect that.
They can't do that.
They do.
But they.
This isn't.
Listen,
this isn't.
I know this. I know.
This isn't speculation. There's been millions and billions of dollars of government fines, as well as court litigation. There's been product liability cases. This stuff.
No, you're right.
This
There are
stuff
case
comes
reports.
out.
There are case reports. Nothing is perfect. There's no doubt.
Well, stop
about
it with
that.
the nothing's perfect stuff. This is legitimate. This is legitimate
I hear you.
information that you just can't dismiss by saying nothing's perfect. People die. Once we've started mass prescribing psychiatric drugs, which there is an absolute dramatic rise through the mid-90s up until today, every measurable statistic from suicides to increasing the amount of people identifying with mental illness, the number of people on disability for mental illness has risen dramatically. It's a failed paradigm of care experimenting with drugs that clearly and obviously have a number of serious problems, so much so that there is a large and coordinated global community of harmed patients that are speaking out of this. It's ranged from permanent sexual dysfunction to suicide to violence to becoming chronically disabled by their condition. Polypharmacy, which is prescribing multiple drugs which have never been evaluated in any clinical direction.
Sure
like combining multiple drugs at once that have never been evaluated with any safety or evidence or efficacy data in a way that would demonstrate to us that that is healthy for a person. We see people who go on drugs have decreased quality of life, a number of metabolic conditions, and then we have the black box warnings and a number of other things. What I generally see from people who are being prescribed these drugs is almost such a high degree of emotional numbness and detachment that interferes with lots of areas of their lives. That gets then misrepresented as mental illness.
I hear you. Can I address, again, many important points, and I'm glad you brought them up. I'd like to address. I'll try to go as quickly as possible. So most studies now are studies of multiple medications. And we have many medications approved for exactly that, to be given
in combination with each other, and they're high quality studies, randomized clinical controlled trials, long-term, following the clients more than 6 to 8 weeks.
Of course. I conduct many of them myself. That's what I do. I look at my review. Just in schizophrenia, just among those, there's so many. Aripiprazole, brexpiprazole, these are all approved approved, not just studied, approved. So that's, and then of course, these medications, like I said, have been around for 70 years. We have many years-long studies of these medications. So that's, now, oh my gosh,
you're saying years long
of these studies.
Okay.
They don't need those for initial approval, you are correct. But in almost every case, we have those.
Yeah, it's up to the doctor can prescribe anything. As long as a single drug is approved for use, a doctor can combine them. And this is what you're seeing. You're seeing
that's
like
true,
antidepressants.
But that's not necessarily bad. That's true, but sometimes people need more than one medication. It's not always good. Less is more. One thing we learned in medical school, one of the first things less is more. If you can do with less, always better than more.
Yeah,
of course.
you might not be observing what is happening in our communities because you're no longer in direct patient care.
No, I do see
but
patients.
It's an absolute tragedy about the degree of which people are impaired on so many different drugs. Their quality of life has decreased to such an extent. I want to actually make
there's one more. I want to address the point that I don't mean to interrupt, but I do want to address the point you made about what's happened since SSRIs came to market. So first, SSRIs are not much different than TCAs, as you know. They're just safer, but they're not much different as you. But that's beside the point. More importantly, you mentioned the suicide, violence rate, those sorts of things. We don't. You're right. We don't. I don't think we've really studied SSRIs and violence much either way. But we do know about SSRIs and suicide. So we have the direct clinical studies, and we have cohort studies, and all these sorts of studies. We also have epidemiologic studies. So people say, I've heard this many times, that since SSRIs, the suicide rate has increased. All these things have increased. Violence. So actually, if you look at the data, in the first 10 to 12 years after SSRIs came to market, the suicide rate in America decreased substantially, and most people attribute that to SSRIs.
It did not decrease substantially.
In the first 12 years.
No, it did not decrease.
Since then.
No, this is the talking point that psychiatrists say. That's not backed up by hard data. There wasn't much. I'm going to post this in the show notes to show the suicide rates in the United States. I'll try to go back to 1900 if I possibly can, and we'll show the dramatic rises in suicide rates correlate directly with more prescriptions.
So, yeah, after 2000, we've had an increase in prescriptions for SSRIs hugely, and a huge increase in the suicide rate.
Yes.
But again, we have to combine that with what we know from the 1990s. Also, what we know from data, from worldwide data. Since the development of SSRIs, the worldwide suicide rate has decreased substantially. So what makes America different in the last 25 years? And again, this is another kind of box that we're going to open. And I mean, there's so much data to go through. But the reason the suicide rate has increased over the past 25 years is strongly supported by the data, and that is the increase in firearm ownership.
Oh, come on with that talking point.
These are the data. These are the data.
That's such baloney.
It's true. Oh, no, it's not just the firearm rate, but it is firearm ownership.
That is such a political talking point.
Those are the data.
That is not. No, it's not with the data. See, this is the problem with the authority bias and the expert.
No, I'm not,
you can just say that's the data without strong evidence to support that case. In most states, you don't even have to register. Like in Pennsylvania, I have firearms. Do you think I have to register that firearm?
I'm not sure what you mean. So what's the point?
You don't know. You're not able to determine who and how many people have firearms. And whether this goes back.
I see what you,
this goes back to your other data when it comes with identifying somebody as mentally ill.
But we know data are not.
What do you mean we know? You just make it up and then you say data's not perfect?
No, we know, but we know for the most part, we know how many guns are sold because we have those records, and so we know by now. I mean,
well, there's more people. Like the population continues to increase.
But per capita. So we have about 400 to 500 million. I mean, it's a wide range, but I mean, we understand 400 to 500 million firearms in the U.S. We really don't know how many are legal versus illegal, but most are legal. And of course, all illegal firearms come from. I mean, they're produced by legal gun manufacturers. So the registration rate is about 1%.
But people have always had access to guns.
I understand that.
And
but the per capita rate of ownership has increased.
What we should be interested as mental health professionals is why would somebody want to end their life with a gun? So that is what has increased.
No.
The amount of people that want to die, they find their life very difficult to live in, and the manner in which we're treating them in Western societies, United States in particular, has been an utter failure. There's some other this is other data. The FDA, our own FDA, has an adverse event reporting system, right? There are 1,530 cases of homicidal ideation linked to psychiatric drugs in that FDA data. But FDA admits there's only like 1 to 10% of side effects become reported. So this could represent, like in a given year, 30,000 cases. The FDA also added homicidal ideation as an official side effect for Effexor XR, which is in 2005. So there is a relationship, or there is identified by our government, of homicidal ideation due to a drug that we prescribe as an antidepressant. 31 prescription drugs disproportionately associated with violence. This is from the FDA. 25 were psychiatric drugs, so 80%. So there's something that there's some common sense, I think, that we have to come to in these conversations. What happens when we experimentally alter states of consciousness on something, on our bodies and brains that have evolved over millennia? In a discrete period of time, we start identifying the emotional reactions and the behavior of human beings to be a brain condition. And then we experimented on a discrete period of time. In that time, we see an explosion of mental health related conditions, suicide, and violence. Right there, we have to ask ourselves, is the paradigm flawed? Forget about the strength of the evidence around a particular drug. We could argue this for days, and I think we're just going to end up boring the audience. I think what is clear is just the fact that you and I are having debate on this is it's not just acceptable. It's acceptable conclusions that these drugs are safe or effective or they decrease the rate of suicide. It is very, very complicated. There's a lot of data that is going to dispute exactly what you said. I know you can find studies that dispute what I said. I would just question the strength of the studies. There's tend to be a ton of methodological flaws. There's a lot of industry-related corruption, conflict of interest, and as many are talking about right now, if doctors themselves, and you actually admitted to this point, that the research that you're relying upon is highly flawed.
I'm not sure I said highly flawed. There are limitations and biases.
Well, I think when we were talking about like John Ioannidis, and I said 85 to 90% of the published research is like very limited, highly flawed. There's often, and this is his words.
You're referring to his.
Yeah, there's conclusions that are drawn that it doesn't really assist practitioners in making evidence-based decisions. And you said you agreed with that.
Well, academics figure that. I mean, that's what I'm saying. Academics figure that out.
He is an academic.
I know, that's what I'm saying. But we figured that out based on the process of scientific communication and replication and all these sorts of things. And so what ends up happening is that, you could go to clinicaltrials.gov right now and type in depression, and you'll find hundreds and maybe even thousands of studies. Almost none of those will come to market, and that represents that 85%. And we kind of just figure it out. That's how things work. Let me get back to suicide and violence. I'll be more succinct with my answers, just to kind of, tie things into, we'll wrap up kind of discussions and share kind of my side of thing, or the side of things of the data that I draw on. My sense is that the data support that antidepressants are effective, that they decrease completed suicide, that they're equivocal with regards to suicidal ideation. That is consistent with what we understand about the neurobiology of violence and suicide. Suicide is even more strongly related to lower levels of serotonin. Violence is also to some degree. That's John Mann, his work. You can clearly see that in his work. We also, just to address a previous point of yours, you're saying that we don't also understand how the medications work, or we should expect some target engagement or biomarker of an effect. We do actually have lots of those EEG measures. We have the PET, the PET, of course, like we can see that the medications bind, SSRIs bind to the serotonin transporter, all those sorts of things. So we have all of that. I was going to make one other point, and now it has escaped me. I was going to mention, I didn't realize this would be as much of a debate. I thought we were primarily going to talk about mass murder and mental illness and perhaps, mental illness in the Bible.
Well, we kind of are, aren't we?
Well, then let me address that one point about, I guess, about violence and antidepressants, if that's okay. Would that be okay to bring up now?
Sure.
So the data show that there's only one psychiatric condition related to murder at all. I'm just starting with it. This is kind of one kind of just foundational piece of knowledge to know, and that is, like I mentioned, early unmedicated psychosis. Minor relationship, but it's there. And then we found something kind of similar in our mesh.
I know you're
database.
going back to
now getting back
You're going back to your talking
the
points.
Medication.
No, just hold on one second. You're going back to your talking points, but we probably went over this for the first 45 minutes. If we can't identify in those research that you've conducted that there is clearly an identifiable medical illness, that unfortunately is just going to invalidate and dispute a lot of your statements.
And we
so
debated
why would we go back and do that?
I was just kind of summarizing what we had shown. Now, specifically,
but I don't want
to
go there because I don't think it's valid, and I made my argument on why I don't think it's valid. I don't think you can. I actually think it's dangerous to say that you can apply a blanket medical diagnosis without ever evaluating somebody, and then trying to infer about who a person is from media reporting or even law enforcement. Prior to coming on this podcast, I interviewed a few people in law enforcement about these very issues. When it comes to homicide, I want to know, like, to what extent do you order, are toxicology reports, for example, ordered? And to what degree do we look at mental illness as being a major factor in completion of that? And I think from a law enforcement perspective, they're going to say, first and foremost, we're trying to convict that person. So they're gathering evidence. It's not in their purview to order toxicology reports or even look into the role of any type of substances involved in that. That might be the defense, for example. So it's not something that's consistent in being able to identify that there could be, an unmedicated person or a medicated person. So there's so many methodological problems with your work. I don't want to get into like a long form discussion to say, well, we know this and we know this, because that's what academics do. They're so used to saying we know, and then you communicate it definitively, and then everyone passively accepts that information as if it's true and begins regurgitating it over and over again. And same with this chemical imbalance nonsense and trying to reduce the complexity of the human experience to like one neurochemical when you admit that maybe on a scale of 1 to 10, we understand a 1. There's so much of contradiction in your statements when you just have to improve the way you deliver the information. If you improve the way you deliver the information to be more accurate, we have a safer culture, a safer society, because a lot of this is pseudoscientific nonsense being communicated with certainty. And that's my biggest problem, because people deserve informed consent. There is no way we should have 1 in 4, 1 in 5 people on psychiatric drugs in the United States. Absolutely no way. And if you want to make an argument that, there's a percentage of people in this country truly, truly suffering, we're going to use this diagnostic criteria. We're going to refer to it as illness. We're going to put it under the medical system. And in some situations, these drugs can improve a quality of life. Then I'm open with you, because then we can talk about who, when, what, where, under what conditions. But that is not what's happening in the United States. What's happening in the United States is there's a lot of propaganda from the pharmaceutical companies that was being spewed back to me today under the disguise as if it's legitimate science, which is exactly what's happening to the primary care doctors. The primary care doctors are writing SSRI prescriptions because they're told exactly what you were told. There's no risk for increased suicidality. They're protective against suicide. Ignore the black box warnings as if the international community just somehow pulled that out of the thin air to be conservative. No, that's not true. The data is absolutely overwhelming. The more you dig into this with court documents, it's dark as hell. I mean, it's really, really dark. And when you talk about methodology, like a pure scientist, like I want to be a pure scientist because I believe in the search for truth. And when you create trials where there's a placebo washing period, when overwhelming amount of trials themselves show that the placebo group outperforms the drug group, and you don't have to publish those, well, then you have a crisis of credibility in research, because all the totality of the data is not provided to our academics. And that's publication bias. And that in itself is indisputable. There's a clear problem with publication bias, being able to replicate data over and over again. And of course, there's no doubt in mental health in the psychiatric field that there's a credibility issue around validity of psychiatric diagnosis. They're overlapped. 65, 70% of those on committees in the DSM receive pharmaceutical money. So you have to be aware of what my listening audience and the global audience that listens to this, they're aware of this information now. So are docs around the world. There are psychiatrists that are pulling themselves out of the system because of this. And they're funneling themselves into burgeoning new research opportunities and treatment opportunities. Functional nutrition or nutritional psychiatry, for example, metabolic conditions. They're pulling people off the drugs, and they're getting better. People are getting better when they're being pulled off the drugs safely. We didn't even get into the problem with what happens when someone abruptly stops the drugs, when someone's tapered off too quickly, which is standard care in the United States. Because we know violence and suicide increase under a number of conditions. Starting a new drug, increasing the dose of a new drug, decreasing the dose of a new drug, adding a drug, and the most dangerous is abruptly stopping a drug. And all those are very, very dangerous conditions. And we prescribe these drugs to teenagers and kids. And my practice is overwhelmed because we see the results of this. They decide to take their drug for a period of time, then they just stop it. Then they have all those symptoms, which is the withdrawal effect of those drugs. They become suicidal. Maybe not because the drug induced suicide, but what happens to the brain, and when you abruptly stop that drug, that can induce akathisia, that can induce worsening mood, that has induced psychosis in a percentage of people. There's a lot of dangerous aspects to haphazardly prescribing powerful psychoagents like this. And it's just so important we provide the public a service to make sure this is clearly identified and discussed. Because as a practitioner in the community and someone who started a nonprofit around informed consent and medical freedom, it's my duty, it's my calling to make sure that people understand the risks that are associated with medical interventions. And we just have to be so careful in the way we communicate. I understand how academics communicate because I got my doctorate in clinical psychology, so you're surrounded by academics. And I go off to various conferences and I hear academics talk about how they present literature. It's the same language, right? We know this, or this is pretty clear, until it gets disputed 5 years down the line or 10 years down the line with new evidence. Why would we want to use that language? We know this. Like, this is the same thing that happened in COVID that created so many problems across this country by obtaining this level of certainty that's clearly not true.
There's some things with which some things you mentioned with which I would agree for sure. I think psychiatry is a specialty. I think specialists should prescribe a lot of these medications. I think discontinuing a medication should almost always be done by a psychiatrist. Because of my role.
But they don't know how to do it.
Psychiatrists?
They don't know how to taper off drugs. The overwhelming majority.
I don't know.
Because
I can tell you.
They're following guidelines from the pharmaceutical industries. They're tapering people off too fast, I can guarantee you.
Well, I don't know about that. I can tell you that
Doc, are you aware what's going on in our communities?
I'm aware. Because I do still see patients, just not part of a clinical practice.
Are you aware of the Maudsley research on drug tapering, hyperbolic tapering?
I probably understand the concept. I don't know exactly to what you're referring.
And so that's my point. Because there's really good science and research that first started kind of grassroots effort from communities of people who can't get off SSRIs because of dependency.
But what did the data? I want what is this? Whatever the Maudsley approach or whatever is, what exactly is that? I mean, I might know it in some other name. Like, I know how to taper people off medications.
How fast do you taper off someone from an SSRI?
Oh, well, it totally depends on the person, of course, and what SSRI they're on, and what dose they're on.
Let's just first say they were on Prozac for 10 years. Let's say they're on 40 milligrams. How fast can they get off of it?
There's always individual variation, but they'd have to come off slowly.
How slowly?
It does depend on a lot of considerations. For example, whether someone wants to get pregnant. These are real things that's not minor. I mean, a lot of people, come off medications because they want to get pregnant.
But let's say we wanted to reduce withdrawal symptoms and the dangers that could potentially come with protracted withdrawal.
Well, fluoxetine is actually one of the better medications from which to come off.
Because of half-life.
Exactly.
Yeah.
So it kind of self-tapers. There are other ones that
but
are
at
harder
still
to come
some
off.
point that it's removed, like the drug is removed from the receptor, right? And now the body is reacting to the absence of it, even, at some point, right? So what
I'm not denying that medications have side effects. There's no doubt about it. And I'm also not denying a lot of the reports you're talking about, the case reports, your patient's experiences.
Yeah, these aren't side effects. This is a withdrawal effect.
Also
in my community, psychiatrists in my region here are getting people off 3-4 psychiatric drugs in a 1 to 2 month period of time. I
believe you.
Yeah.
I believe you.
And they're psychiatrists.
I understand.
And I'm a psychologist, and I don't want anything actually to do with this, but I've been thrown into the conversation, obviously, because I'm having the conversations with people. So people around the globe contact me. can you help me get off this drug? Is there someone you can refer to me? And the overwhelming psychiatrists in the United States I have conversations are like this. You've never heard of the Maudsley approach or hyperbolic tapering, or even aware of the epidemic of withdrawal.
That's different. Trust me, I know how to use medications, and I know how to take people off medications. There's no doubt about that. Whether someone uses the Maudsley approach, whatever, I don't even know what that means. But trust me, I know how to take people off medications and put people on like taper and withdrawal.
I think psychiatrists know how to put. That. I think psychiatrists know how to put people on drugs. I don't think they had to take them off. How long would it take for you to get someone off Effexor?
Again, it depends on the dose. It depends on the person.
Full dose,
depends on what
10 years.
Medications.
Because this is what we're seeing. People on Effexor for 10, 15, 20 years now?
See, what happens is you start with Effexor. So with Effexor, what you would do is because of this low half-life, you would generally first cross-titrate them to something like sertraline or fluoxetine. And that's how it works.
Yeah, that's what we're seeing, and we're seeing horrible results from that.
Right. But that's the best. Listen, nothing is perfect, but that's the way to do it. And
I disagree.
Sometimes it works and sometimes it doesn't work. But
that's not good enough. That's not good enough for the people who are harmed. So it's not perfect. Sometimes it works. Sometimes it doesn't. When there's a better way. There's a better way. Hyperbolic tapering is small reductions, like 10% reductions in dose, like a month. 10% reduction a month. And sometimes it takes years for people to get off the drug, including a reinstatement of a very low dose near the end of it. And we're seeing much better outcomes because what's happening is they're doing that. Psychiatrists are doing exactly what you described. Like you're prescribing another drug to get off of one drug.
One way.
You're doing it fast. They're having withdrawal reactions. They come back into the office. The psychiatrist says, here's your mental illness returning.
I hear you.
Do you understand that's your colleagues? Like your mental illness. This is why you need to be on the drug forever.
I wouldn't paint so large of a breath. And trust me, I mean, I think you said that's hyperbolic tapering. Is that what you called it?
Hyperbolic. And I'm not being hyperbolic.
No, I understand. No,
that's a standard of care.
I hear you. That's a phrase. I've never heard that phrase before, but that just describes slow tapering, and that's fine. I mean, we're totally familiar.
It's a little bit more. There's a curve in place, and there's a process involved in it.
But that's like how people on other not related to this podcast, or maybe, I don't know, I haven't listened to every single one of your episodes, but many of them. I actually appreciate a lot of what you do. But that's like how I hear in a lot of podcasts people say that, oh yeah, medical students receive no training in nutrition. And it's at first you think
very
maybe
limited.
That's true. No, but I mean,
or poor training.
But then you realize,
like don't eat red meat, like nonsense like that.
But what's nutrition? Nutrition is biochemistry. I mean, medical students get more than a biochemistry. I mean, that's what nutrition is. I mean, just because I don't know that something is called hyperbolic tapering doesn't mean I understand. I'm not familiar with how to, different methods for tapering people and, discontinuing medications. But I wanted to get to, no, there was another important point. Oh, gosh. Oh, yeah. Just in terms of the whole chemical imbalance theory, whether SSRIs would work, I did want to mention people use tryptophan depletion to, decrease serotonin and see whether that causes depression. That's a relatively weak way of decreasing serotonin. If you actually decrease serotonin and dopamine using alpha-methyltyrosine, or what happens with people after they use cocaine and LSD, they have a crash, which is what happens when you have AMPT. You immediately become depressed and suicidal in most cases. So again, there are lots of. I'm just using these data to illustrate that there are lots of lines of evidence that support that SSRIs would be effective, or why they might be effective. Why we are pretty confident about the chemical imbalance theory and all these sorts of things. There's so many other points I wanted to get. I've forgotten. You made a lot of good points. Oh yeah. I did want to mention. I want to validate most of what you're saying, not all of it. I don't know as much about pharmaceutical companies. I do know that all trials now are on clinicaltrials.gov, and if they're not, one wouldn't be able to. Certainly, a pharmaceutical company wouldn't be able to use it as a registration trial. But yeah, I want to validate, like you said, totally 1 in 4, 1 in 5 patients are being prescribed psychiatric medications in the U.S. Many of them may be prescribed inappropriately. Most patients are prescribed psychiatric medications from their primary care physician, who may not know how to use the medications as well as a psychiatrist. I understand that you feel that psychiatrists aren't maybe much better than primary care physicians.
No, I mean, that's why it's being done. I mean, there's...
I figured I could make that.
Yeah.
I could claim that.
In some cases,
I don't believe that, but I understand.
In some
that you
cases,
feel that way.
I'm just worried that it's worse.
I hear you. Because you feel that
there's just so many...
there's an incentive or something.
Well, so first of all, that's your specialty area, okay? If you had to acknowledge a lot of the points that I made today, and I think they're valid, I think they're grounded in evidence, I think there's a swell of harmed patients and real questions about the validity of our mental health system in the United States. You may be protected in a bubble in New York City. I'm aware of that. But it's such a swell that the tidal wave is going to overwhelm everybody, right? And so we have to be aware of what is happening to harm patients across the globe. We have to be really focused on what works and what does not work. We have to communicate scientific findings accurately, clearly, transparently. And that day of just blindly relying on some of this data coming out from very poor studies, even though they might be published in something like the Lancet or the New England Journal of Medicine, like those days are now over, and there's an awakening. And so I feel kind of bad because there's a lot of things you said today that I think are going to come back to hurt you. And I'm going to want you to come back on to be able to defend yourself, because we're going to clip a lot of this, and I'm going to be honest about it. Like, we're going to clip a lot of the statements that you made because they were very definitive. I think that's really problematic for where we are now as a nation in our healthcare and trying to communicate this effectively. There's also a lot of debate that exists from psychiatrists. So this is not a Roger McFillin clinical psychologist debating the psychiatry world. I think there's a lot of things that you said today that are up for debate and challenge, including Joanna Moncrief and a number of other medically trained doctors who either pulled themselves out of the system or are focused on communicating this stuff directly, or are on the front lines of like drug tapering to get people off drugs, because what we're seeing is people get better when they get off drugs. And I'm going to clearly state this. In my practice, clients are improving in front of our eyes when they safely taper off drugs. Now, with a lot of support and with other interventions, but the drugs themselves are really impairing quality of life for many people. It is not a better life to be sedated or blunted emotionally. It does not in any way align with our historical understanding of emotion regulation. It does not in any way relate to a robust information on our ability to adapt to life circumstances. Like, we are very, very resilient. You can go through a very hard time, meet the minimal criteria for what we label as clinical depression, and in all likelihood, you're going to move past that. And on the other side, there's a lot of growth and transformation that occurs. But what happens when you start telling people that what they feel is an illness? It's genetic, it's outside their control, it's a brain disorder. You fundamentally impact their own understanding of their human experience. There's an invalidation process because there's a lot of people who are suffering who are in very adverse conditions. It could be, trauma, some of the worst of it, like when you see somebody in a really dangerous situation, or young children in communities where there's violence and poverty, and you start drugging them. What are the implications of that as a model, as a paradigm? Do they move through it and do they grow? No, they don't. They become, what happens psychologically is you end up getting in almost a war or a battle with your own emotions and thoughts. The idea of viewing them as symptoms of an illness is something that has consequences that we rarely talk about. So my clients become scared of their own emotions or scared of their own thoughts, which I think you would agree is fundamentally incompatible with living well and being well. And it's unfortunate what we're doing in this country because we're affecting generations, and the consequences are really severe. It's a lot gets blamed on COVID for the mental health crisis, but when you actually look at the data, it was on an upward trajectory of mental health problems. A practice like mine should not be as busy as it is. As an industry, the therapy industry, the psychiatrist, there's way too many of them, right? It's not like, hey, this is an advancement in health by having more therapists and more doctors prescribing drugs, and that is elite mental health care, or that's the pinnacle of scientific supremacy. When you start comparing outcomes to other places in the world that don't have that same model, I mean, that's a whole nother podcast for another day. You know, you start seeing that the Western allopathic approach to mental illness is a failing paradigm.
Well, let me address some of these points. Yeah, we definitely disagree about the data, and that's okay. It's okay to have a debate. I didn't quite expect that we'd have a debate, but that's okay. We had a debate. Now, to back up a little, maybe talk about something with which or about which we could agree a little more. I believe, although we talk about medications, that's certainly my area, and I do neurobiological research. I fully believe, again, coming from Columbia especially, in the biopsychosocial model of psychiatric illness that strongly, strongly is
that
puts strong imports on the psychosocial component.
Is that a materialist perspective?
I'd have to know exactly what you mean by materialist, but I learned, and I know Columbia is probably one of the few programs in the country now that still teaches a lot of psychodynamic theory and therapy. I think that one thing society's done, which is very unfortunate, is that we have
I think that's harmful
thrown
too.
the baby out. You think psychodynamic theory is harmful?
I think it can be. I think it's often misapplied, misunderstood, and not that helpful.
Well, I think we've thrown the baby out with the bathwater. The bathwater being, Freud's psychosexual theory, which I guess a lot of people don't like, but the baby is all psychological theory. I think not only is psychodynamic theory a great way of understanding people. See, I think your expertise is, if I'm not mistaken, DBT and eating disorders. There are no medications for eating disorders right now, as far as approved for eating disorders, as far as I know.
They prescribe them, though.
And there's a lot of comorbidity in eating disorders.
No, they'll prescribe an SSRI for an anorexic.
Therapy is also very helpful for people with depression and schizophrenia. I mean, almost all patients, not necessarily all, but almost all. I also agree with you. If we're prescribing psychiatric medications to 60, 65 million Americans, or at least lifetime, maybe not at one time, there are going to be many examples or case reports or anecdotes of significant side effects, bad situations. A lot of those people, again, because our diagnostic criteria only have 80 or so sensitivity and specificity, there are going to be a lot of cases in which these medications don't work. Having a number needed to treat of 7, for example, means that you need to treat 7 people with a medication to obtain, in this case, remission or relapse of depression. That means a lot of people are just not going to respond.
Those numbers mean nothing.
When
we set up the entire podcast and talk about the problems of published research, we can't just throw out numbers like that. That's ridiculous.
But the point is just that means that a lot of people are not going to respond. And so I understand a lot of people don't respond, and we do our best. I can't speak to every psychiatrist.
Most people don't respond.
Prescriber.
Right. When you look at the absolute.
But that's what I said. If a number needs to treat means,
I don't even think that's accurate. But,
I know, but even that, that means.
Do you know people get better on the placebo?
I'm aware of this. That number needed to treat incorporates placebo. That's what it means.
But yeah, I mean, the degree to whether it's pain, mental health, the degree to which people get better believing that they're taking a drug is so meaningful. This is why I asked about the materialist paradigm, because the materialist paradigm is something that's going to start reducing everything down to the material. Like there's a biological process eventually that's going to be causal in this, where the post-material sciences incorporate quantum physics, the biofield and energy healing. There's great work coming out of Columbia. I wish I had her name. I was trying to look for it. There's this whole new evolving post-materialist science that demonstrates like all these new ways or different ways that we have an effect on each other, on consciousness, on matter. Like it's very, very complex with like a lot more sound methodological studies than exist in psychiatry. So like if we fundamentally don't even understand things like the nature of consciousness or quantum reality or quantum physics, the biofield in medicine, if we don't have those type of conversations in mental health, then it's like getting in a time machine and going back to 1985 earlier, 1990, and starting saying things like the biopsychosocial model and psychodynamic therapy.
No, I hear what you're saying. No, listen, we don't have to understand. We can understand 1% of the brain. We understand less than one. I mean, I'm a fan of Neil deGrasse Tyson, and he and Michio Kaku, they often kind of remind their listeners, and I think appropriately, and I appreciate this, they remind us the scale of the universe and how little we know.
Yeah.
I forget which one says that for all of what we know and for how powerful we are, we can't even do or understand what one cell of a blade of grass can do, which is photosynthesis. We don't understand how that works. But that doesn't mean you throw out
I think what
everything
it
else.
says is at least speaks to humility.
Of course.
Right.
Naturally. But we work with what we have. I mean, it doesn't mean we just stop and we don't do anything.
But we have more. And when you're in the bubble and you're reduced to the material paradigm and you're in a profession that has aligned itself with the pharmaceutical industry, that's why I said you take away these drugs and the role of the psychiatrist in the greater healthcare system disappears. You'd have to reinvent yourself. So there's such an inherent conflict that exists. You have to defend the drugs because you're prescribing them, because you're studying them, you're researching them, you're communicating it from that paradigm. You're the only psychiatrists that have these conversations with me are the ones that said, "Yeah, I know," and I left. And there's lots of them, you know. And I do believe. Part of this is a profound disappointment because I think we need medically trained physicians in the mental health realm, because I think there's so much we can be doing with lifestyle. There's so much with innovative research around like light and metabolic health and nutrition. There's sleep. Like there's so many aspects of this.
All that research is being done.
I know, but it's not what's being provided as the standard of care in our country. And I bring in those physicians to have those conversations. But how we practice is Stone Ages. I mean, we're still pushing pharmaceutical drugs. And if you meet you never meet a psychiatrist who thinks the same way around these drugs. Like I'll get like 10 different patients. They're all given the same diagnosis. They're all treated with so many different drugs over, 10 years. They're all horrible. Like they're doing really, really bad. But somehow they've been brainwashed to think, well, I've got this illness for life and I just have to keep taking these drugs. And so I do think we're inducing chronic mental health conditions by the way that we're treating them. And at some point, do you know in our communities that there'll be teenagers or young adults where a doctor will say, lay out a couple drugs and say, pick one. Like that's how bad that it's gotten. And nurse practitioners.
I don't know about that, but listen, I mean, I can't comment. I've not heard of that. Maybe it happens. I mean, listen, I don't know what to say about that. But what's happening in psychiatry, you might not agree, might not disagree with this. The state of research and whatnot in psychiatry is not much different than in other fields of medicine.
Oh, it's much different.
No, it's very similar. I mean, we did.
How can you say that? How can you say that when it's subjective and you can actually make statements here that we have a biological basis for this, but how much money has the NIH dumped into trying to identify mental illness as a brain condition? So much so that they've abandoned it?
I'm not sure they've abandoned it.
The dollars.
Lots of research on. I'm funded to, examine the pathophysiology, like neurobiology of psychiatry. I'm not sure. What do you mean abandoned it? I'm not sure.
Well, the dollars aren't there in the way that it used to be. Now there's certainly money that's being invested in various aspects of physiology and biology and mood and elsewhere, but like as far as like that decade of the brain and the amount of money that we devoted 90s into like 2015, that paradigm is we've kind of moved away from it because it just hasn't produced results. It hasn't done anything to move the needle. In fact, if anything, in my opinion, obviously it's much, much worse, but it certainly hasn't reduced the burden of even severe mental illness in this country.
Sure it has.
Oh my God, Doc.
No, there's no doubt about that.
Doc, you think we've reduced the burden of mental illness in the United States?
Severe mental illness. So I would look at mental illness, this is what I was talking about. I would look at mental illness the kind of way we look at cancer. So rates of cancer are
That's
increasing.
a problematic comparison.
No, it's I mean, what do you, anyway, the rates of cancer
Because we're
are
not really
increasing.
good at treating cancer either.
But, so this is so the analogy is actually I think pretty strong. So the rates of cancer are increasing. So the question is why have we failed? Are our treatments for cancer just no good? Do they not work? They do work, and we have more treatments than we've ever had, and some of them are amazing. But cancer rates are rising. But we have to understand really why they're rising. They're rising for maybe 2 or 3 main reasons. 3, I think. And this is actually maps very well onto mental health. Number 1, earlier identification. Number 2, people are living longer overall. I know in the past couple of years there's changed, but overall people are living longer. So you're older,
But people
you're
are
higher risk
getting cancer younger now than at any other point.
And maybe 4, and increase of rates of obesity, which is strongly linked, to cancer, of course, and then increased substance use. Those 4 things. Psychiatry is not much different. So, but we're able to treat cancer much better. Psychiatry is similar. We're able to treat more severe mental illness better. Remember, rates of chronic hospitalization have gone down. So severe mental illness, they've gone down, while rates of mental illness have gone up. We can treat the most severe forms. We disagree about the data, but for example, suicidality and stuff like that. And again, we can keep people out of hospitals. So the severe mental illness or severe kind of forms. It's similar to cancer. That's what I'm saying. They're very similar. And again, people do. I can't go through every study. I don't know every study, but if we compare mental health in general or depression and psychosis to diabetes, you have type 1 diabetes, which is very different than type 2 diabetes. Type 1 diabetes is purely genetic. It's just, that's it. Type 2 diabetes is mostly, it has a familial component, but it's very environmental and social, right? Maybe to a larger degree than depression and psychosis, for example. There's a much stronger biologic component. There's a psychosocial component. There definitely is. But it's smaller than, for example, the environmental component to type 2 diabetes, which is almost exclusively related to overweight and obesity and those sorts of things. So, we do the best that we can. We have research methods. We have bias and limitations in what we do. We try to address it. We do the best we can.
Well, I want to give you credit. You are the first person who actually stated that we're actually doing a good job and we're reducing the burden of mental illness in this country. You're the first person I ever heard that.
Mental illness is increasing, but our ability to deal with
I said reduce the burden.
I guess we'll just.
There's more.
There is more mental illness. There's
There's more people disabled by a mental illness diagnosis than at any other point in measurable history.
I'm agreeing with you.
So I don't think we're reducing the burden when people become disabled. They can't work.
I'm agreeing with you. There's a lot more that we need to do, and we need to figure out what's going on. But first, it's not the medications, Kaisen. But number 2, we were specifically talking about the severe forms. Cancer is increasing, mental illness is increasing. More people are affected by these things for sure.
Yeah.
I'm saying that we are.
I think we should. I think we should question the paradigm for both. The manner in which we understand cancer and the manner in which we understand mental illness. I think they're both great examples of how poorly we are in producing outcomes through Western medicine. I do agree with that comparison. I don't think we've reduced the burden of cancer. I don't think our outcomes have improved. I think there's more people developing cancer and younger.
That's true. But I just didn't say that. That's true. I
agree.
And
I don't think our outcomes are strong at all.
They're getting better. So the rates of death are decreasing, as they are, for example, like I said, if we're looking at the severe forms of the conditions, they're improving. But yeah, the overall burden is increasing. I'm agreeing with you.
Yeah, and same with mental illness. We have more people identifying with mental illness.
I agree.
We have more people disabled by mental illness. We have
You're
lower
right.
quality of life of people who are mentally ill.
You're right.
Their life expectancy is reduced. The drugs are factors in metabolic illness. So the weight gain,
they have side effects.
And the health-related conditions that are associated with people who get placed on those drugs. In my opinion, many of these conditions that are drugged would have been episodic conditions that could have more safely helped move somebody through that condition and come out the other side. But we've just created this narrative in this country that mental illness is a brain condition. Once you have it, you can have it forever, and then you need to be on these drugs forever, when we clearly don't have data that supports that. And so what we're doing is we're creating a burden of mental illness for a large portion of people that should have never been in the system in the first place.
Mental illness, for the most part, is episodic. That's right. We do have data that suggests that medications, and they're actually approved for maintenance treatment, like the prevention of relapse and those sorts of things. I mean,
horrible data. I mean, horrible data. Like, I mean, those things have
clinical trial
never
data. I mean, I don't know what, the clinical trials. I don't know what.
Yeah, I mean, this is why this is one of the reasons why Bobby Kennedy is heading HHS, right? Because of being able to understand the corruption that took place in our government agencies and industry. That drugs got brought to market that should have never been brought to market because they didn't really meet baseline safety and efficacy. And it becomes a turnstile, like of FDA reviewers end up going and working and making big money in the pharmaceutical industries, right? So just being able to say that because it received FDA approval from a trial that was conducted by the same company that is going to benefit from that drug being to market is not the same thing as saying that means it's effective and it's safe.
I was referring that's just shorthand because we can't discuss every single trial. I can't even remember every single trial, but that's just shorthand for discussing the specific trials themselves.
Yeah, I mean,
there are trials.
We're in fundamental disagreement.
We do disagree.
Fundamental disagreement
about the value of the studies.
About the values of the studies, about the health of this country, about the mental health system that we continue to fund from government that continues to expand while people continue to experience a higher burden of mental distress. I think we fundamentally have a different viewpoint of the human experience. Yours is a relatively very small, short period of time in all of human history. Right? We're talking about, only a few decades of this shift in paradigm that we can find a drug like insulin for diabetes and that we can cure these conditions. I mean, that was how it was discussed in the 90s. How old are you?
45.
I'm 49. So you and I kind of came through that era. And, that was really pushed. We're one of 2 countries with direct-to-consumer advertising. It really has been sold to the American public that you take this drug and it reduces the burden and, it's a standard of care and just accept it, right? Take the drug. It's what's going to help you. And we've gotten therapists to recommend it, therapists who know nothing about this. It's like an absolute joke. You have like a 25-year-old who just graduated and she's recommending like a 16-year-old to go on an SSRI. I mean, it has become absolutely fundamentally criminal. I don't know how, well, I do know how we've gotten here, but one of the way we've gotten here is that there's been too many experts who are repeating the narrative and actually selling the narrative for the pharmaceutical companies. It filters down from that area. So I'm going to kind of try to close out the podcast episode on you and I have 2 different perspectives, and we were able to passionately discuss that today. And I actually value that, and I'm passionate about this. I've had to sit with too many people harmed, and I'm kind of on the front lines of a movement trying to look at what have we done professionally to create this burden and this harm. And I'm past throwing myself into the data on this. I feel like I got a good grasp of it, its limitations and its challenges. But you willing to come on here and have that discussion is meaningful to me. And I think it's meaningful to our listeners because people can actually take a step back and say, all right, well, what do I think's going on? Like, how can I make informed, decisions? What does he believe that shows strong evidence that we should support him versus what's Dr. McFillin saying? And, I feel like I have to challenge the expert. Like, that's my job on this. But I'd have these same conversations behind closed doors. Obviously, you probably get that sense from sitting with me. I'll give you the final word.
Yeah. No worries. I appreciate you bringing me on. Again, I also appreciate the work with, if I can say his name, your colleague, Ralph.
Oh, yeah.
I appreciate, communing with both you and you all being so hospitable. I want to mention again, I didn't know this would be, quite be a debate, but I mean, that's okay. Everything else, I think, I think we agree about the state of mental health. I think it's more about the cause of the state of mental health about which we disagree but very clearly, if I can say that. Something is clear. The etiology of where we are today is maybe what we disagree about the most. Maybe.
Yeah. No, I mean, listen, you're a standard trained academic psychiatrist.
I'm pretty traditional in that sense.
Yeah, like extremely traditional.
Very. Oh, yeah, there's no doubt. But I was
Professor
clear
at-
about that.
Yeah, you are. Professor at an Ivy League school. You're at the epicenter of it, right? And so your willingness to drive down from New York and to be here and have this conversation. You probably didn't know what you were walking into fully.
Not quite, but whatever. I mean, it's okay.
Yeah, no, there's usually those who understand what I do. You say I'm not going to enter into that conversation with you, which I think is a problem in our field generally. Like we have to have these conversations. These debates have to happen, and I think it's an ethical. It's a legal and ethical mandate, really, because how do you provide informed consent to patients? You know, let's say you're going to suggest an SSRI. You know, how do you communicate to that patient, like what it does? What are the effects of that? What do you need to pay attention to? You know, if somebody is, I probably should have this last point. If somebody is going to be prescribed a drug and there's the probability they could have permanent sexual dysfunction, become suicidal. And I think you agree that taking the drug and compared to a placebo has shown to increase suicidal ideation, right?
In some, I think overall, I think the data are equivocal, but that has definitely been shown in some studies.
Yeah, Lexapro, for example, was just published, I think it was 1 or 2 years ago, a study for 7-year-olds to 18-year-olds, so as children as young as 7. There was a 6-fold increase in the Lexapro group compared to placebo. About 10% of the kids became suicidal as young as 7, versus 2%, for the placebo group. So I mean, those were staggering numbers. The data was clear. And do you know what the conclusions were by the study authors? Lexapro is safe and tolerable.
Right. I don't want to open up another kind of bag to go. I could address that, but I'm not debating the.
I mean, why would you?
I don't know the study. I don't remember.
I mean,
it,
why would you give
believe,
Why would you give Lexapro to a 7-year-old who's anxious? I mean, then I would have been put on Lexapro at age 7.
No, I believe the veracity or validity of how you reported this study. That probably happened. Those are probably the data reported by the study. I believe you.
Yeah, I mean, the big problem is the study authors were also receiving money from the pharmaceutical company that produces Lexapro, AbbVie. And that's a clear conflict of interest, right? And those go into guidelines that like pediatricians use.
But just to be clear, I don't want to get into too much. I know we're ending now, and I appreciate it, but I actually enjoyed myself. I don't know. I didn't expect it, but I enjoyed myself. It was fun. I appreciated speaking with you. I've not to extend things too much longer, but I first learned of you while I was watching you on Allie Beth Stuckey's podcast.
Oh yeah.
And you know what? Even though we clearly don't agree about a lot of things, I just, for whatever reason, I appreciated your episodes.
Oh, thank you.
I appreciate what you had to say.
Yeah. So the next time that you'll be on the podcast, we'll be with a couple other medical professionals, psychiatrists who disagree with some of your statements today, and we can agree on that.
I'd love to meet Dr. Moncrief.
Okay, I'll get in touch with her.
I mean, she's very prominent.
Yeah. I think she's doing great work.
She credibly reported the results. You have to give. I mean, that was great. The results of the studies that she reviewed.
Dr. Ragy Girgis, I want to thank you for an absolute radically genuine conversation.
Radical, yeah. Thank you.